3, the final part of our survey of bacteria. All right, so epsilon proteobacteria, we're going to look at Helicobacter and Campylobacter. Helicobacter is known for H. pylori. You can see it's a kind of spiral shape with flagella at both ends. And so multiple flagella, and you could add to that polar, right? Because it's at both ends. And it's a microaerophilic organism, meaning that it can only tolerate small amounts of oxygen. If you try to grow it under normal conditions, it will not grow. And this makes sense because it's in our stomach where we're constantly swallowing air, right? So there's limited oxygen in our stomach, but our actual intestines are completely anaerobic. So thinking about the environment that it's living in, that explains its characteristics, right? All right, so about 50% of the world population is infected, but only about 15% will have symptoms. And it looks like my slide is a little messed up. But this says that 15% of people who are infected will develop gastric or duodenal ulcers. And so remember, the duodenum is the part of the intestine immediately after the stomach. Okay, and this image here is showing that about 80% of people with a H. pylori infection are asymptomatic. They're totally fine. But they could also have chronic gastritis where it's inflamed, maybe have mild symptoms of it being inflamed, but only about 15% will actually develop an ulcer. So you can see here an ulcer where it's damaged, inflamed, and the ulcer is an open wound, right? So you have actual damage to the lining of the stomach or the duodenum, like I said. Very rarely, right, 1 to 3% of individuals will actually develop cancer, and it's believed that this is just from all of the irritation and just repeated irritation. So people who have chronic acid reflux, right, are usually given medication for the same reason, is that the constant irritation can lead to cancer. So if someone's experiencing symptoms of an ulcer, they might be tested for H. pylori. We can do this a few ways. The best way, the most definitive way to know what's going on is to take a small biopsy, look at it under the microscope, and do a culture. Of course, that's invasive. Not everyone's going to do that or even going to be able to afford to have that procedure done. Some places have some advanced technology to do a breath test called a urea breath test, which is great because it's non-invasive. It's super, relatively fast and easy. Again, that's not always available. And so the probably most common procedure then is collecting a stool sample and looking for the antigen, the specific markers on the pathogen. Okay, and it's fairly reliable. Now, H. pylori is interesting. It can get into the mucus layer that protects the lining of the stomach and disrupt it, and it can also what's the word I'm looking for? It can take the stomach acid and convert it into ammonia, so going from acidic to alkaline, because it will secrete large amounts of the enzyme called urease. And so H. pylori actually changes the pH where it is colonizing the stomach to be alkaline. So that's interesting. So if you do have an infection and you are being treated with antibiotics, it's also common to take bismuth, like Pepto-Bismol, to help kind of line, coat, and soothe that ulcer. Never try to just treat an ulcer on your own. You definitely want to get, at that point, if you have symptoms of an ulcer, you want to get an endoscopic procedure where they can take images and know exactly what's going on, especially because if you have any precancerous areas, they can take biopsy and make sure you don't have cancer. If you are developing cancer, you get early treatment. Okay, so it's very interesting, right? So 50% of people have it. Most people have no symptoms or very mild symptoms. About 15% will have an ulcer, which is, very uncomfortable and can be serious if not dealt with. But all of that's fairly, especially in light of the things we've been studying, doesn't seem super important. But because 1 to 3% can get stomach cancer, it needs to be handled carefully. Also, interestingly, there seem to be some complex host microbe interactions because, one, to explain why only 15% are developing these ulcers when so many people have these infections. We also see that blood type O seem to be even more prone to developing these ulcers. So, like, the majority of this ulcer group will be blood type O. So that's fascinating. So yes, it's H. pylori. We're learning more and more about it. It's very interesting stuff. We're also seeing that there are fewer cases in the developed world. So good sanitation practices, right? Having wastewater treatment, water treatment, getting people to wash their hands after they use the restroom. All of these practices are reducing the transmission in the developed world, like I said. So it is fecal oral transmission. It might also be transmissible through saliva, but that's a maybe. We need more research to confirm that. All right. Next, Campylobacter. And I apologize. I know I updated the slides once more again today. And maybe I'll just go ahead and update the module again so that you have these. I want to make sure that I'm making it as easy as possible for you guys, that you can take notes as I teach, but that you still have a good chunk already there for you. So yes, that's why this looks different than the slides you have. So Campylobacter it used to be the number 2 cause, and it is now the number 1 cause of diarrhea in the U.S. It used to be number 1 in the U.K. Because of their love for pate, which is like undercooked poultry. But now, just because all poultry is contaminated with Campylobacter, and so many people have moved away from eating red meat, and they're eating more, poultry, we have seen an increase, right? If you're not having good food hygiene, maybe you are contaminating. So maybe you cook your chicken all the way, like most people do, but they have it on their cutting board, on their knife, and they maybe are contaminating other things with the chicken. So let's see. The organism is also microaerophilic, like we saw with H. pylori, and it looks pretty similar, but it has a single flagellum. So, they're closely related. They're in the same group. And typically just do rehydration therapy, but if someone has symptoms for a week or more, they go to the doctor, they could be given azithromycin to help clear up the infection. But it usually does clear up on its own within a week. So a little bit more about Campylobacter. The symptoms: fever, abdominal pain, cramping. The cramping can be quite severe and lead to dysentery. Other people have more mild symptoms and they'll just have regular diarrhea. It is a true infection. The only way to really diagnose it would be to isolate the bacteria in a stool sample. We usually just go off of symptoms. Depends on the physician, depends on the severity of the symptoms, I suppose, as well. So the reservoir is chickens and cows. So 60% of cattle are excreting this in their feces and in their milk. Another common source of infection, in addition to having undercooked chicken or cross-contamination, is also unpasteurized milk, where another weird trend we've been seeing this the last 5 to 10 years of people thinking vaccines are bad and people thinking pasteurized milk is bad, which is just the most bizarre thing to me. These are staples that protect us from so many diseases. Like, there are a lot of diseases that are common in milk, and pasteurization is the best way to kill the pathogens. It doesn't kill 100% of bacteria. There's non-pathogenic bacteria in the milk that will eventually lead the milk to spoil, but the pasteurization is killing the pathogenic bacteria and keeping you safe. So I don't know why we're getting these weird trends of people going against what the scientific community is saying and what's been proved for very long amount of time. There's nothing unsafe about pasteurizing your milk. There's no harmful byproducts. There's no chemicals involved. It's just heating it up, killing the pathogens, and cooling it back down. So anyways, I'll move on. The incubation time is pretty short, just 2 to 5 days after ingestion. You don't need a particularly large amount either to become infected. And as I mentioned already, usually about 1 week it'll clear up on its own. But some people get very severe infections, and it can last up to 3 weeks for them. Typically, like I said, if someone's coming into the doctor where they've had these symptoms for a week, they will be given azithromycin or some similar antibiotic. Very rarely, people can develop a temporary paralysis, which is like an induced autoimmune attack, because there's a molecule that is very similar to a neurological molecule, and so it can cause some issues there when fighting the infection. It is rare. I think it's 1 out of 1,000 cases, but we do have over 1 million cases annually in the United States alone. So it is very, very widespread infection, right? Because people are constantly coming in contact with both, we have people that work with the chickens and the cows, and then we have all the people consuming dairy products, meat products, poultry products, right? So there you go. Good hygiene practices will reduce your frequency of gastroenteritis. Okay, firmicutes. This is finally, we are on a new phylum of bacteria, right? We were in proteobacteria forever. Huge group. Okay, now we're looking at the firmicute phylum. All of the organisms in this group will have a low GC composition of their DNA. So they have more AT base pairs than they do GC in their genetic code. Okay. They're also all gram-positive. So finally looking at some gram-positive organisms. Here's another example of a dichotomous key, just to show if you were to do a quick analysis of the GC content and find that you do indeed have a low GC content and you're working with a gram-positive organism, then you would want to look, does it have a wall, have a cell wall, or not? Remember, we saw very briefly that there is a group of wall-less bacteria called the mycoplasmas. They're the tiniest cell that we know of. And everything else is going to have a cell wall. It may produce endospores and be a clostridium. It might be have endospore and be a bacillus, like Bacillus anthrax. Or it doesn't have endospores and it's a lactobacillus. Most of the lactobacillus we think of as friendly, good gut bacteria. All right, so let's start with Clostridium. And remember that's here, so it's low GC, gram-positive, has a cell wall, produces an endospore, is anaerobic, so does not utilize oxygen to grow, cannot use oxygen. And so then that leaves us with the Clostridia. Okay, so Clostridium, we're 1, 2, 3, 4. Yeah, I deleted the fifth species. The fifth species was dangerous to cattle and not so much people, so I removed it. So you can go ahead and change this to 4 species. So Clostridium botulinum can cause botulism. It releases a neurotoxin, and that's what causes botulism. So if you ever see a bulging can like you see in this image where the sides or the top is bulging, you dispose of that right away. Very important that no one consume that. The only reason for a can to be bulging would be that gas is being produced. How is gas being produced within the can? Bacteria are growing. And if bacteria are growing inside that can, it is bad news. It means it was able to survive the canning process. Most likely an endospore, most likely Clostridium botulinum, or even Clostridium perfringens, right? In any case, it's bad news. You don't want to consume it. Okay, so what happens with the neurotoxin is it will actually stop the muscles from being able to contract, and so you'll get this flaccid paralysis is what we call it, and it kind of starts from the top of your head and eventually works its way down. So you first typical signs and symptoms are double vision or blurry vision, droopy eyelids, right? So the muscles in the eyes and in the eyelids are now not able to fully contract. You can start to then have it go farther down the face and have slurred speech, difficulty swallowing, dry mouth. You can't even get enough saliva because all of these processes require your muscles. And then you might actually start to notice other like skeletal muscle weakness, like in your arms. Of course, if this goes untreated, it will get to your respiratory system and you will die from not being able to breathe. We do have an antitoxin that we can administer if someone comes in with botulism. Okay. C. difficile is a pathogen of actually huge problem in hospitals and other healthcare settings. It's an infection of the intestines. It's particularly difficult to treat, and it causes awful diarrhea. It in low amounts in the intestine can be a normal flora, but if someone is receiving particular types of antibiotic treatments, then you kill off some of your to overgrow, and then it's nearly impossible to get it back down to a normal level and allow the gut flora to go back to usual. And so this can be quite debilitating for people, especially if those are people who are also trying to recover from some other illness, right? Since this is usually a hospital-acquired or healthcare-acquired kind of result. Now, it's not that they're getting infected from being in the hospital per se, but because of the antibiotic treatment. So it can happen to someone in the comfort of their home if they're taking long-term antibiotic treatment, right? Okay, so Clostridium perfringens can cause gas gangrene, which would be when the skin has like a cut, a wound, and the Clostridium gets in it, and it releases a toxin that actually breaks down the tissue and produces gas. And so I spared you the image. If you're curious, your textbook might have an image, but you could also Google it to see what does gas gangrene look like. It looks like dead skin that's blistered up because there's gas underneath it. So gas gangrene, and that typically requires amputation. I almost always requires amputation at that point. But if you ingest it, it'll cause food poisoning from that toxin. So luckily, it doesn't break down your tissue of your intestinal tract. Rather, you just get a lot of vomiting and diarrhea to flush it out. Okay, and usually that resolves in about 24 hours. Then there's tetanus. So Clostridium tetani, sometimes called lockjaw. So this causes paralysis, but instead of the flaccid paralysis that we see with botulism, it's the opposite, where the muscles are stuck contracting and they're not able to relax. There's no cure for tetanus. There's only prevention. There are about 1 million cases worldwide of tetanus. The Clostridium bacteria, they all form endospores, and they're all everywhere in the soils of the earth. And you just really need to get vaccinated. You should be getting a tetanus shot every 10 years. So that's it for Clostridium for now. A few more firmicutes. Staphylococcus aureus, which we've talked about off and on throughout the duration of our course. It does produce a yellow pigment. However, you would have to have a scanning electron microscope to be able to see that, or special media, perhaps. But that's where it gets its name, golden. Okay, depending on where it gains access, right, it can infect pretty much any area of the body. It can cause UTIs, it can cause respiratory infections. Most common are skin infections, and we talked about MRSA being methicillin resistant. Staphylococcus aureus and MRSA and MRSA stands for vancomycin, another category group of antibiotics. MRSA, the I is for intermediate, and then the Staphylococcus aureus does not form spores. Okay, so we saw Clostridium here, all spore-forming endospore. Staphylococcus does not have endospores, and then Bacillus anthracis does. And you are familiar with Bacillus anthracis already from our very first lobster, right? Remember, if you inhale the spores, you can get a respiratory infection. If you ingest it, you can get gastrointestinal infection, and even can get in your skin and cause a cutaneous infection. The most important or lethal form is respiratory. It can cause an acute respiratory disorder. So respiratory infection is the most severe form, and again, it's from inhalation of spores. And you can go back and look at that first lab if you want to review a little bit more about it. Those spores are pretty much always going to be present in the soil, and then cattle who are constantly breathing in air near the ground can very easily become infected, and then transmission can happen from there. Okay. These links are optional for you. All right. One more example, the lactobacilli. You've probably heard of lactobacillus. It's in a lot of yogurts. It's in a lot of probiotics. It's an aerotolerant anaerobe. It's not going to utilize oxygen, but it's not going to be killed by it either. And there's also there's a member specifically that I want to talk to you about, and it's Listeria, because this is foodborne and causes a lot of gastroenteritis, but it's very dangerous if you're pregnant. It can lead to miscarriage or stillborn or premature birth. I don't have an explanation as to why. Maybe you'll research that and teach me. But it is a very sad complication of Listeria infection. Symptoms: fever, headache, stiff neck, confusion, loss of balance, and convulsions. So very serious infection here. Listeria, that's one pathogen that I find to be very scary. Another reason to have really good food hygiene, cook your food, and be very careful. Okay. And I think your textbook has a little bit to say about Listeria, whether it's in the gastro digestive system chapter 24 or 25, or in the survey, I can't recall. But you can look that up in your textbook and learn a little bit more about it as well. Streptococcal pharyngitis, or strep throat as you're used to calling it, is caused by streptococci bacteria, which we call group A or gas organisms, and almost always is Streptococcus pyogenes, but there are a couple other species that fit into this group A category. These organisms have special enzymes and properties which we call beta hemolytic, means that they are able to completely break down blood cells and actually turns out pretty much any type of cell. And if someone has strep throat, they do not have any symptoms besides the fever and the throat. So the site of the infection is going to be very red and swollen, and usually you'll also have pustules on the tonsils, and then the fever, and that's it. So it'll be incredibly sore. You won't want to talk. You won't even want to eat because it hurts to swallow, right? And so it'll be so severe that you will be going to the doctor to get antibiotics. The good news is that it resolves really rapidly with antibiotic treatment. The reason we give antibiotics, though, is not because the infection is so painful, even though you would think to. Um, and also the development of rheumatic fever can happen, which we'll talk a little bit more about in a minute. Um, Streptococcus pyogenes can cause skin infections as well. So it's not limited to the throat, but strep throat is a common issue that we need to talk about. We have rapid tests, so you just the physician takes a swab, swabs the area of the throat, especially on the tonsils, and then sticks it in the tube with the test, and it's a rapid antigen test. So we are looking for the antigens on the bacteria, which means we have the antibody that matches it already in our test, and there will be some indicator, usually a color change, to indicate a positive. Okay. We'll also usually send that to culture and make sure that the antibiotics prescribed actually work. And as I mentioned, it can cause a lot of other diseases, including flesh-eating skin disease, and scarlet fever, which we're going to look at. So, yeah, that's everything I wanted to talk about for this. Okay, so scarlet fever, we don't see as many cases in the United States anymore. It used to be fairly common. Now it's mostly common in developing countries. Strep throat, however, is pretty common here. There's a toxin that the bacteria produces, and the toxin seems to be responsible for this different set of symptoms. So you get a rash, you get a really incredibly red throat, you can get a sandpaper-like rash on the tongue. You'll see here, in fact, I'll just show you here. So we have this really red, swollen throat, but no pus. It is very different than what we saw with strep throat, and also seeing like this strawberry like rash on the tongue, and then you see their arms, their back, like they're just covered in this rash. Okay, so that's why it was called scarlet fever, because it turns you red. And so rash on the tongue, neck, underarm, groin. It starts out being a flat, smooth rash, but then it will eventually turn to fine bumps and feel kind of like sandpaper. You can have nausea and vomiting with this infection. And the complications, like I said, any Streptococcus pyogenes infection can lead to rheumatic fever. And so rheumatic fever is inflammation of the heart, joints, and kidneys. And this can lead to permanent scarring and permanent damage. Some people will develop like a type of arthritis from this, and that will cause them pain for the rest of their life. But of course, your heart and kidneys, vital organs, even a worse complication. So it can happen. That's why we will always treat these infections with antibiotics. Mainly children are infected with Streptococcus pyogenes, whether it be strep throat or scarlet fever. It's most common in ages 5 to 12. Scarlet fever, as I mentioned, is a hypersensitivity reaction to the toxin that's being produced. Not all strains of Streptococcus pyogenes produce this toxin, and it's becoming more and more rare in the United States. We believe that the bacteria, the strains of Streptococcus pyogenes that cause scarlet fever, are producing this toxin that's actually a viral toxin. And so it's actually when during the life cycle, what we call life cycle of the virus, it has inserted its DNA into the host. The host will replicate, and eventually at some point in time, the DNA will come the genome, and viruses will start to be assembled, and you'll have a huge release of viruses. And so this is called the lysogenic stage of infection. So the bacteria itself is infected, and that's what's causing the scarlet fever. So very interesting, kind of complicated, right? So that's a good introduction to Streptococcus pyogenes. I did not include slides specifically about the skin infections, but you can look that up if you're interested. Pneumococcal pneumonia caused by Streptococcus pneumoniae is a diplococci with a capsule, as you see here. This looks a lot like this image looks a lot like the image we saw for the encapsulated diplococci that caused gonorrhea, meningitis, that caused meningoccal meningitis, right? So another diplococci with a capsule. Streptococcus pneumoniae, fever, chills, cough, rapid breathing, difficulty breathing, right? It's pneumonia. You have fluid in the alveoli interfering with oxygen exchange, pain in your chest, and the complications is that this can actually turn into meningitis for some people. Treatment, heavy antibiotics, macrolides, or fluoroquinolines. We do have a vaccine, and it's primarily given to, I think, age 50 and up. Not 100% sure on the age cutoff there, but this tends to be more of an issue for, older populations, not the college age that we saw with the Neisseria, right? Interesting. Neisseria meningitis looks just like this, and can cause meningitis, where we have Streptococcus pneumoniae that the complication can also be meningitis. So makes you wonder, what is it about the capsule that allows it to cross the blood-brain barrier? Okay. So now we're on to another group of gram-positive organisms called actinobacteria, and these are fungi-like. They'll have interesting growth. They look very different than all the bacteria we've seen so far. They're gram-positive, and they have a high GC content, so opposite of firmicutes, which have low GC. Now we're looking at high GC content. Okay, another dichotomous key. Make sure you're comfortable looking at them and interpreting them. And again, you do not need to memorize these dichotomous keys. So the actinomyces group are very interesting. They have filaments, and they have kinetiospores, so they're very much like fungi, but they are actually bacteria. And we get 2/3 of all of our true antibiotics come from streptomyces. And they actually also produce spores, and these are fungi-like spores that are used for reproduction. This is not the same as the endospores that we've learned about that are survival dormant forms of bacteria, right? So spore is not the same as endospore. Be careful with that. We also have a group called our Corynebacterium, which we have nocardia, which can cause pneumonia, and we also have diphtheria, which you should be vaccinated for, right? It's with the DTaP, diphtheria, tetanus, pertussis. Okay, diphtheria is It's very serious. We'll talk about that in a moment. Then we also have mycobacterium in this group, tuberculosis and leprosy. So we'll look at those next. Okay, so tuberculosis, there's a lot about in chapter 24 for the respiratory system infections. So instead of going through each of the systems one by one and going through all of the infections, we are breaking it into all of our bacterial infections. Then at another time we'll look at viral infections, and at another time we'll look at fungal and helminth infections, right? So just a little different organization than your book has. Okay, so Mycobacterium tuberculosis, we do not have a vaccine in the United States. There is a vaccine in Europe. The United States decided to do a screening approach instead of a vaccination. So if you're in the United States, you don't get the vaccine, but you do take a TB test from time to time to ensure that you're not infected. This is an acid-fast organism that we've talked about before, and it is transmitted person to person through air droplets, right, in the air. There's also a strain called Mycobacterium bovis that can cause infections in people from the cow or the dairy product, but that makes up a very small percentage. The vast majority of tuberculosis comes from Mycobacterium tuberculosis, person to person. These infections are chronic. They last a long time. Nearly 1/3 of the entire population of Earth has a TB infection. That's incredibly high, right? An incredibly large amount of people are infected, and over 2 million deaths every year because of it. But of course, the chronic infection can lead to a very compromised, poor quality of life. Now, we can treat it, but it's actually very difficult to treat, a long amount of time on antibiotics. We also see that of all the tuberculosis cases, 1/3 of the tuberculosis patients are also HIV positive, which is another infection that we've been trying to get under control as well. And I'm sure you know quite a bit about HIV because we've had a lot of campaigns to try to educate the population about it. Okay, so tuberculosis, early symptoms can be asymptomatic. You don't even know you have it, and at a later point, you then start to develop symptoms of pain in the chest, fatigue, fever, weight loss, and then it can continue on from there, but it might not. Okay, so that part will differ from patient to patient. We will go over a little bit. We'll look at the parts of the infection and what's actually happening in a moment. I just want to give you that global perspective of the areas where the most tuberculosis. You can see that Asia has the highest, most widespread amount, but when you look in Africa, we have very high levels, very dense regions where tuberculosis is endemic. Then you look at the United States, and there's almost no infections, but it's not none. There are some, right? And it's not only 24 infections in the United States. It's 24 per 100,000 people. So you would need to multiply that by the total population to see what that actually amounts to. And since we started screening for it, our cases per 100,000 dropped from 100 to that 24. And so this shows that the approach of screening was actually very effective, and that, we did not have to vaccinate to take care of tuberculosis. That's not always, in fact, rarely would that be the case, but the way that tuberculosis is being a slow infection, this has worked for us. Okay. We also see, as I mentioned, Asian Pacific Islanders, much higher amounts. So it seems that, reported tuberculosis cases per 100,000 population among American ethnic groups in 2009. So Americans that are Asian and Pacific Islanders have more tuberculosis than Hispanic Americans, right? So this is just an interesting observation of the populations within America that have tuberculosis. It does not tell you why, and I definitely don't want you to assume that that it has anything to do with immigration. In fact, it most likely has to do with genetics, making people more susceptible. Okay, but it could also have to do with, people already having the infection. We do screen when people come over to the United States from other countries, so we should be able to prevent that. But it's not perfect. Okay, so part one, pathogenesis of tuberculosis. First, you need to inhale it, right? So the bacillus, which here is shown as already being inside of a macrophage, but just imagine it's not in a macrophage yet. So it has to first be inhaled and reach the alveoli of the lung, and then that's where it will be ingested by the alveolar macrophage, right? But our alveolar macrophages are not actually good at killing this slow-growing pathogen, and so typically this will continue to develop into an infection. Okay, so some of the bacteria survive within the macrophage. The infection is technically present. They start to slowly grow within the macrophage, but you do not experience any symptoms yet. Then we see it says tubercle bacilli, but we mean like the Mycobacterium bacillus pathogen, right? Starts multiplying within the macrophages, and this causes the recruitment of more macrophages to the scene. So you see here, through the blood, more macrophages arrive. They go into the alveolus and try to help, but they're actually not helpful. And so we have the beginning of the tubercle forming here. So it's actually our macrophages that cause the actual tubercle, but because they will be infected with the bacillus bacteria. Okay, so tubercle bacilli multiplying in macrophages cause this chemotactic response that recruits more macrophages to the area. So it brings additional macrophages and also some other defensive cells, which are not really shown in this image. So our immune system's trying to fight this infection. It's trying to take care of it. We're not able to kill it, so then we try another response, a defense mechanism, which is to just try to wall it off. And so you'll see that in the next step. So we form a surrounding layer destroying the bacteria. And in fact, they will continue to release enzymes, cytokines, in an effort to try to fight the infection. But it's in vain. It doesn't kill the bacteria, and it actually causes damage to the lung. It causes inflammation, and this is where you start to experience symptoms. So after a few weeks, disease symptoms appear, and you have the tubercle now forming, and you'll have like a hollow middle called a caseous center, and you'll see dead phagocytes shown in kind of dark red. They're infected, and now they're releasing more of the bacteria, and you have this big mass of macrophages trying to prevent the spread of this bacteria. So after a few weeks, disease symptoms appear as many of the macrophages die, releasing more of the tubercle bacilli and leading to this caseous center in the center of the tubercle. The aerobic tubercle bacilli don't grow well in this location, but they do, however, remain there. They're not killed. They can remain dormant and survive for a long time, and this would be latent TB. This would show up on a CT or an X-ray, like this mass. Okay, and this poses a risk if this tubercle opens up. If it gets damaged, then you're releasing all of this bacteria into the lung, and you'll have a more serious next stage of infection. But some people, it will remain in this dormant stage indefinitely. And then this lesion, this tubercle, will become calcified by the immune system, and that would be the end of the symptoms that the patient's experiencing. Unless it becomes disseminated at a later point in time, then symptoms would reappear. Okay, so in some individuals, the disease symptoms appear as a mature tubercle is formed. The disease progresses as the caseous center enlarges. This becomes more and more active, growing bacteria. And this process is called liquefaction. So bacteria start to grow, and they're this caseous center is now going to become full of air-filled tuberculosis cavity, we call it. And then they can start to multiply outside of the macrophages that you see here. And eventually that will rupture open the tubercle and allow it to spread. And this usually allows it to not only spill into the bronchial, but disseminate throughout all the lungs and even into the circulatory and lymphatic system and cause severe symptoms. So, and as you can imagine, having all this dissemination puts the patient at great risk, and this is where the fatality, the deaths from tuberculosis will come from this stage here. So if you do have tuberculosis, you'll have to be on antibiotic treatment, usually 2 or more antibiotics for at least 6 months. And one reason this long treatment is TB is still so prevalent. So the reason that this long treatment is a contributing factor to not getting tuberculosis under control, right? People in other countries don't necessarily have access to health care. They cannot afford like I mentioned earlier, there is a vaccine, but it's not used in the United States. If you have ever had that vaccine, you definitely do not want to do a screening skin test because you'll test positive. So you would want to show your proof of vaccination instead. And depending on the scenario of why you were getting screened, you may or may not be asked to do a chest x-ray or CT to confirm that you don't have tuberculosis. Now, how this works is a small amount of the tuberculin is administered just to the surface layers of the skin, and it'll make just a little blister, which should just heal. And so within 48 to 72 hours, you have to come back to the either nurse or doctor, and they will check your arm to see what happened. If you respond with redness or increased size of the blister, then it would be positive. Of course, there are some people will have a small reaction, some bigger and bigger to be considered positive. I don't expect you to memorize any of those details, but just so you know, anyone who's like immune compromised is not going to form as big of a reaction, and so for them, they would be considered positive with even just a small reaction. Whereas like a normal individual, healthy individual, with no known risk factors would have to have a rather large reaction to be considered positive. But again, you don't need to memorize this much detail. I just want to introduce you to the concept. Yeah, that's it. Okay, here we go, diphtheria. So diphtheria, where was it? Way back on here. So I mentioned it earlier when I first started to introduce you to the actinobacteria. So diphtheria is that third of the DTaP. We already talked about tetanus. We already talked about pertussis. Now, diphtheria. Okay, so prevented by the DTaP vaccine. So we have the vaccine that's given to children. We have the booster that's given to adults. It is a slightly different vaccine, but it does prevent against all three, diphtheria, tetanus, and pertussis. Okay, so this bacteria has a toxin, and it's also due to being lysogenized, so it's a virus infected bacteria is why it produces this toxin. But in this case, pretty much any diphtheria that we culture will be of this type. So it's not rare like we see with scarlet fever. It's the majority now. Okay, what happens is toxin will kill some tissue. It'll form what we call pseudomembrane, which is gray dead tissue, but it's very, very sticky, so it remains in place and it can block the airway, and then you would suffocate. Okay, if the toxin gets into the blood, it can cause severe damage to the heart and kidneys as well. So two ways that diphtheria can kill a child: block their airway off, or they manage to still breathe. They'll have difficulty breathing regardless because it'll be a narrowing of the airway. But if they get lucky and it doesn't block off their airway completely, they could still be at risk of damaging the heart and kidney from the toxin. Symptoms: weakness, sore throat, swollen neck, fever for a few days, and then you'll have that gray membrane formation. So when you could look in the throat of the patient and actually see it. And of course, severe difficulty swallowing and breathing. 10% mortality rate for people with these infections. I put for unvaccinated because if you're vaccinated, you're not going to be infected. So get vaccinated and keep up We do technically have antibiotics and antitoxin that we could use to treat a patient. But again, depending on, if you detect it in time, you can help them, give them some treatment. But it's tricky because the initial symptoms, weakness, sore throat, swollen neck, and fever is very generic, right? Like most colds and flus. So there's no guarantee that you would get to the doctor in time to get treatment. Interestingly, you can also get cutaneous diphtheria, which would form an ulcer on the skin that will take a long time to heal, but is not really particularly dangerous. Before the vaccine for diphtheria, we would have 1 in 10 patients die, and if it was a child under the age of 5, that number went up to 1 in 5 children. So very lethal. You'd have about 200,000 cases every year in the United States alone. So very thankful for these vaccines. People who are most susceptible to an infection are those who are not completely immunized, so they didn't keep up with their immunization. They don't have full coverage, but they're not necessarily taking any precautions, or they've been exposed to a carrier, so someone who doesn't have symptoms, right? That's another risk as well. So again, follow up with your vaccines. This organism, this bacteria, has a club-shaped cell where it's kind of rounded and thicker at one end. So it's an interesting shape. And then here you can kind of see that grayish membrane forming. Okay. You can also read about this in your textbook. All right, we are almost done. Our last group, non-proteobacteria that are gram-negative. All right, so we were forever talking about the proteobacteria, which are gram-negative. Now we're going to look at another group of gram-negative bacteria that are not proteobacteria. Chlamydia. Chlamydia is interesting. It forms these tiny cells called elementary bodies that then get inside of the host cell. So this could be cervix, cervical tissue, for example. And then once inside the host cell, it will induce a vacuole to form. And then once inside that vacuole, which will then be called the elementary body will change into what will be called a reticulate body at that point, once it's in the vacuole. And then you'll start to see rapid cell division. And then eventually the reticulate bodies begin to convert back into elementary bodies. And then you get the release. So this is very interesting. I don't know of any other bacteria like this, where the infectious agent is the elementary body, but that's not the form that replicates, right? So you have to get inside of the host cell, have mentioned this and when we talked about other STIs. Also, if you have chlamydia, you're much more likely to also have a co-infection with either gonorrhea or HPV. And remember, HPV puts you women at a much greater risk of cervical cancer, which is why we now have a vaccine for HPV. You have to receive it early before you're sexually active. And what else? Oh yes, pelvic inflammatory disease. We also talked about before, which can lead to infertility. If it doesn't cause infertility, it can still cause chronic pain. Usually no symptoms for this infection, but if you do have symptoms, they could include an abnormal vaginal discharge or a burning sensation when urinating, or a discharge from the penis, swelling in one or both testicles, although that is much less common. Here's an optional link for you to watch. And we're almost done. Another group of bacteria called spirochetes, and you can see because they look spiral. And Borrelia burgdorferi is known for causing Lyme disease. It is spread through a tick, so it's important if you are in an area where ticks exist that carry Lyme disease, you need to do things like tuck your jeans into your socks to basically seal off your legs so they don't even get exposed. When removing your garments, you should check your skin for any ticks, just in case. And also showering before you go to bed is another good way to help remove any ticks. It does take time for the tick to burrow into the skin, so within 24 hours is the best prevention, but it can take as long as 48 hours for those ticks to penetrate. But once the tick is under your skin, you're not going to see it, you're not going to know it's there. Once it's completely under your skin, it does not take long before the bacteria will be released and start multiplying. Okay. Some people will develop a bullseye rash, but not everyone. This would be a really obvious sign that you have been infected. But like I said, unfortunately, not everyone develops this. This rash is not painful. It looks like it'd be painful, but it's not. But it will be warm to the touch. This could be in a place that you don't see very well. So some people have it, don't know they have it. Others just simply did not develop the bullseye rash for some reason. Symptoms of Lyme disease, besides the rash: headache, painful, stiff joints and muscles, fever and fatigue, and they can last for quite some time. And if it goes untreated, some people will develop complications with the central nervous system disorders. There's another type of Borrelia that can cause recurrent fevers, also tick-borne, but also sometimes lice can transmit it as well. And that's it for Borrelia. But syphilis is also a spirochete that we need to talk about. So Treponema pallidum is the spirochete bacteria that causes syphilis. Any mucosa or even any break in your skin can lead to an infection. So direct contact and or sexually transmitted, right? The primary stage, which you see here, forms a sore called a canker, but surprisingly is not painful. This will occur at the site of infection, typically 10 to 90 days after exposure. 90 days is unusual, it's usually faster. sage can lead to rashes and loss of hair. And then you'll have a period of no symptoms. And at some point later in time, years later, you can start to have those sores forming on your internal organs. And then that can lead to permanent damage of wherever the sore is, including nerves, eyes, heart, brain, and other organs. Can be fatal. Okay, so also if you're pregnant, you can give this to your child and cause neurological damage. We do have a rapid screening for this. If for any reason you think that you could have been exposed, get tested. Okay. So primary stage, it's not painful, but it is super, super contagious. Second, and of course, this could be anywhere on the body, wherever you contract it. It's going to be at the site of infection. And then that'll heal, go away, but then you'll develop a rash, the body, and you can also experience hair loss wherever the rash is. And so this shows stage 1, anywhere from 3 to 90 days after exposure, you get the sore at the initial site of infection. Anywhere from 4 to 10 weeks later, you can have that body rash and have a loss of hair. And then years later, and this is 3 to 15, but it could be even longer than that. But most cases are between 3 and 15 years, and then your internal organs are affected. And this is an example. Now, of course, this is on someone's arm, and this is showing it going all the way through the skin. It's quite extreme. It's definitely possible, but it's also happening internally. So this can be a little confusing of an image, I believe, which is why I included this one here for you to see internal organs. So there you go. Leptospirosis was the other example of kidney infection that is not from working its way up the urethra that I was trying to think of earlier. And it's a spirochete, so that's why it's here with spirochetes. So leptospirosis would be the disease caused by leptospira, and this is rodents for the most part, wild animals, but sometimes dogs can be infected. And if you come in contact with their urine, so you have a skin wound or your mucosa, like your eye, gets in contact with the urine from the animal, or water that's contaminated with the urine from the animal that's infected. First phase, headache, muscle aches, fever, vomiting. You start to feel better, and then the fever returns, as well as jaundice, yellowing of the skin, and the whites of the eyes, because now the liver is not functioning as normal. It's inflamed, infected, and then pyelonephritis, the kidney infection. Okay, we can confirm that it is actually leptospirosis through collecting the sample, testing it for antigen, so serological tests, and we can treat it with doxycycline. And there's a neat, cute little video short to talk about this, just a couple minutes. It's good to watch, help you remember it, but everything you need to know is here. So that's everything I wanted to tell you. We never talked about the archaea in this very long bacterial survey, and that's because they don't cause disease. But there is one organism that we should mention before we call it quits, and that's Thermus aquaticus, because we're able to have this technique called PCR, all due to this organism that lives in hot environment, hot springs. And so since it lives in a hot environment, its enzymes have to be able to tolerate that high heat work function. enzyme that replicates DNA, and we call it Taq after its name, Thermus aquaticus. So Taq polymerase, because we're able to get this, we're able to perform a lab technique called PCR, polymerase chain reaction. I think I have a little bit about it. So PCR is an amplification technique where we can copy DNA, and you don't have to culture organisms in order to do PCR. You just have to have a single sample, and then you can do a DNA extraction on that sample, and you can run PCR, and then you can analyze it. So a single sample is not going to have enough DNA to do an analysis on. You need to first do PCR. So it's such a huge revolutionary tool. We've learned because of PCR that there are millions of bacteria that we never even knew about, right? We've learned that there's over 10,000 bacteria in just a single gram of soil. We had no idea. So the scope of microbiology, the world of microbiology was opened up so much bigger. It was like, you know, when we learned about Hooke and Van Leeuwenhoek discovering microbes for the first time, it was like that all over again. But we've also been able to utilize PCR for things like crime scene investigations, and paternity tests. So it's a widely used technique for all sorts of lab work. Okay. Lots of bacteria have not been identified yet because we are not able to culture them in the lab. So PCR allows us to even discover them for the first time. Why would they not be able to be cultured in the lab? They might have special nutrient needs that we don't know about. They might have complex interactions with other organisms in order to exist, right? All sorts of complexity that we don't know about and don't even maybe have the ability to recreate. So that's it. You're officially done with your survey of bacteria. I provided a few practice questions for you. I also started an outline, and I suggest you continue that outline, but I've also provided you a study guide. Lots of resources for you to see how well you're retaining the information. Study, 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 memorize. I know it's a lot to memorize, but hopefully you also find that it's a fascinating world of diseases. Microbiology can be a lot of fun, very interesting, and most importantly, we can save a lot of lives. All right,